Welcome to Ask Dr. Geier Live. Sorry, my mic is in the shot a little bit. Hope you are having a wonderful Friday afternoon wherever you're watching. Hope you're making today your masterpiece. It is that time of week where I answer your orthopedic questions, whether that's injuries, muscle, tendon, ligament, bone, anything like that, whether it's surgeries that you're about to have or you wonder if you need to have, whether that's recovery, whether that's rehab, any of that kind of thing. I am happy to talk. I'd love to hear from you if you have questions, comments, or if you just want to say hey like Georgia does. Hello, Georgia. And Bina, it's good to see you. This, remember though, is not medical advice. I am giving you information and education, or for educational purposes only. I haven't seen you, examined you, looked at x-rays, MRIs, any of that. So I am not treating you. I am not your doctor. You're welcome to come see me in Charleston, but that is, in fact, if you want to do that, the link to my website is in the description below, drdavidgeier.com. Go to the contact page, fill that out. That gets to me and my assistant, and we will set that up here in Charleston, South Carolina. There's other ways we could work together potentially too, but this is your chance to ask me questions for free. Holly, it's good to see you as well. All right, Bina says, I have an ankle sprain. You're not gonna be able to upload anything, but if you just give me the gist of what it is, I can give you my thoughts. Typically, that's a strain or tear of the ATFL, sometimes the CFL, even less likely, but sometimes in severe ones, the PTFL, or it can be a medial ankle sprain, not nearly as common, but the deltoid ligament on the medial side. What's interesting on an MRI for an ankle sprain is whether or not there's any chondrals, some cartilage injury, bone bruises in the talus, things like that, or other injuries entirely. That's kind of what you'd look for. Yeah, partial ligament tear. Put that on the screen. Partial ligament tear is what Bina says. Yeah, that would make sense. MRIs, I don't typically order MRIs for ankle sprains very often, unless either somebody is just not getting better, it's been 6-8 weeks and we just can't figure out why, or on the primary one where you're kind of wondering if there's other injuries involved other than just the ankle ligaments. Typically, the only time I would do it to sort of gauge severity is when it's a pro athlete, has been my experience. Partial ligament tears, though, typically are much quicker. That tends to be sort of the grade 1 area, again, at least for a lateral ankle sprain, and usually 1 to 2 weeks. But again, hard to tell you that for sure. Holly says, BPC 157 or other peptides take the place of surgery for complete tendon tear like the Supraspinatus or Infraspinatus? So that's a great question. Most of the studies on BPC are animal studies, quite honestly. There was a case series of patients, I don't remember how many, 20 maybe, that had BPC 157 injected into their knees, presumably for arthritis, even though they didn't really work it up, and those people had great pain relief. But the studies on muscle, tendon, ligament injuries, in this case, tendon injuries like the Supraspinatus and Infraspinatus, two of the rotator cuff tendons, that's what you would look at. The most of the studies that I've seen for tendon injuries, the animal studies, have been on the Achilles tendon, where they completely cut the Achilles tendons and then use BPC, and yes, they did heal. And that is a surgery, or that would, in theory, replace the surgery. Now, to be fair, Achilles tendon surgeries or Achilles tendon tears in humans often heal without surgery. The problem is they almost always, not almost always, but a lot of times they re-tear. That's why in high-level athletes and really high-functioning active people, we tend to still fix Achilles tendon repairs surgically. But could it help somebody? Again, you're sort of trying to translate animal studies to humans, but could it help somebody with a rotator cuff injury, maybe an older patient with a torn supraspinatus and infraspinatus? Would BPC be enough to get it to heal? It's hard to know. You would hope it could. It certainly, the animal studies that are out there would suggest that it might, but I certainly, we don't have enough human data. We don't have data specifically on rotator cuff problems because that's hard to study in animals that may or may not have rotator cuffs. It would be hard to know. Certainly I would expect that it might help with pain. I just don't know how much it would improve healing, improve strength, get it back to normal, that kinds of thing. And again, for those of you that are not real familiar, I haven't talked about peptides in a long time. Those are still considered experimental by the FDA, at least a lot of them. There are some that are FDA approved now, semaglutide, tirzepatide, the peptides for weight loss are now FDA approved and have been for about a year. And there's others, but BPC at least is still considered experimental. If you're going to get it, try to find a functional or integrative physician or integrative medical practice to prescribe them for you. Do not get them from online sources. Those are almost always fakes according to studies that I've seen, and they have been found to have high levels of contaminants and fillers, and they're just, you don't know what you're getting. You might not actually get peptides, but you might get something fairly dangerous. So I would strongly recommend against that. If you're going to do peptides, do it under the supervision of a pharmacy that is well versed in that, has a peptide certification. But having said that, I would hope that it helps, but I certainly couldn't tell you based on scientific evidence that it would. But if somebody can't go through surgery for a certain reason or doesn't want to go through surgery and you say, hey, could I try that? You certainly could. The nice thing, if there is a nice thing about a rotator cuff tear, is that it's not something you have to do right away or else. There's a lot of surgeries we do in orthopedic surgery that you need to do it in the first few days or week or two, or that surgery gets really hard. That would not be one of them. Now, rotator cuffs are something you probably wouldn't necessarily want to wait a year, 2 years, something like that, because that tendon can gradually retract and becomes harder and harder to repair. I went on and on about it, but those are kind of my thoughts about that. And yes, Holly, I see BP. I figured. I get a lot of questions about BPC. It is very, very popular. Ever since somebody, and I don't know what physician did this, but labeled the combination BPC 157, thymosin beta 4 or TB4, some people call it TB 500, and CJC 1295 with or without ipamorelin, and called that the Wolverine Stack. It is very popular in the bodybuilding and powerlifting world, and probably pro athletes as the Wolverine Stack. Wolverine the movie, Hugh Jackman, he can get injured by anything and he instantly heals. Well, somebody called that stack of peptides the Wolverine Stack. Yeah, the talar bone fissure, Bina, is what I was talking about. That's the bone on the undersurface of the ankle. Let me get my model here. That is this bone. So when you get an inversion injury, you just get basically a compression injury of that bone, and you can get cartilage damage. Not much you can do about that, but it also, if it's fairly mild, very often not a big deal. Georgia says, still bruised on the inner thigh where they took the ligament for my ACL surgery 4 months later. So inner thigh, I would assume, and correct me if I'm wrong on this then, because usually your options, if you're taking tissue, doing an autograft, taking tissue to make a new ACL, you use either the patella tendon, here, let's show these. You are taking either the patella tendon, you're taking the quad tendon, or what's not shown here, your hamstring tendons. You take it from a small incision on the inside of the top of your tibia, the proximal tibia, but then those go up the back of the knee. I'm assuming that that is a hamstring tendon is what they took. Typically, that can be sore. One of the issues that I have had in women that I've seen I don't do hamstring grafts in females typically. It's just not my preferred graft for a number of reasons kind of outside of this discussion. And one of the things I see is that they say, yeah, they get a cramping in the back of their thigh, but a lot of times too, they feel like their knee hyperextends more or something like that. So I'm not... it's not my thing to use, but having said that, I have seen people talk about sort of prolonged soreness. There's not a lot you can do about it. Really work to strengthen the remaining hamstrings with a physical therapist would kind of be my main thought. You are so welcome. All right, any other questions? I will stay here for just a few more minutes. remember, as always, if you want to actually see me in Charleston, South Carolina, whether you want to talk about regenerative medicine treatments and sort of alternative treatments like Holly was talking about, or just traditional orthopedic surgery and sports medicine, I am very happy to do that. I see patients in Charleston, South Carolina and Charlotte, but I usually bring people from out of the area to Charleston. I just saw somebody yesterday from California, so certainly happy to do that. Just reach out to me through my website, drdavidgeier.com. I don't know why it would be bruised and not sore. You would think the bruising would have gone away by now. That I agree. That's a little unusual. I don't have a good sense for that. I appreciate that. Shows a great resource. 40-year-old active lateral uni knee replacement, all kinds of running. It depends on who you ask about that, whether or not running is contraindicated. Some of you have heard me rant about the tread on a tire analogy before you get a joint replacement. That's a little misleading. You do a lot of impact stuff. It wears out the cartilage in your knee, the tread on a tire. Arthritis is not just a compression issue, but once it becomes metal and plastic and you do put more stress on it, with things like running, in theory, you're just going to have it wear out faster. But I'm sure there are joint replacement surgeons that would say, hey, it's fine to run on it because we'll just convert you to a total knee replacement. Others that might say, hey, try to preserve that as long as possible. Georgia, you're very welcome. I didn't see 40-year-old man. I'd be really, I guess my nerves would be, so if a uni-compartmental knee replacement, and for those of you that don't know what that is, they basically, instead of taking out the cartilage and bone on the medial side, the lateral side, and under the patella, they're just doing it in one of the three compartments, in this case the lateral. If that wears out sooner than would be expected, then you're talking about potentially a total knee replacement at 40 or 45. I've got to think the problem with having a knee replacement too early, and we used to do these in people mostly in their 80s and 70s, and that slowly trickled down to the 60s and 50s, and yes, we're starting to see it in the 40s, is those joint replacements. Yes, there are some that make it to 25 years. Typically, at most, it's more like 15 to 20 years. So at 45, you're almost certainly going to outlive those. First surgery is a big surgery, but it's certainly recoverable. But the second surgery is a monster surgery where you're having to take out the components. You lose a lot of bone. You're doing a revision prosthesis. It's a lot bigger of a deal. So I try to get people, that's largely why I do anti-aging and regenerative medicine, is to help people push that surgery back further and further and further so that you don't potentially need a revision, but even better would be if you don't need the joint replacement in the first place. So that would be my potential concern. I don't know anything about you or how soon or how long that unicompartmental knee replacement would be expected to last, but I would think the concern would be if you run on it, whatever they tell you, 10 years, 15 years, you're going to take a few years off of that with running. Now, the argument would be, well, it keeps me active, keeps me from getting overweight, obese, minimizes my risk of cardiovascular disease, things like that. So it's good for my overall health. I get that, but that would be the potential concern. What if cortisone shots don't work for shoulder bursitis? It really depends on what the real issue is. Cortisone, I'm not a big fan of for shoulder bursitis because that's usually not the problem. It's usually sort of supplemental. It's more of an impingement of the rotator cuff tendons, and you've got to correct that issue. So getting in, working with somebody with that's really good at physical therapy should be able to get rid of that. I'm not a big fan of cortisone generally for that, certainly not as the only thing you do, but there are studies that show that cortisone weakens the rotator cuff tendons, especially multiple cortisone shots, and increases the risk that a rotator cuff surgery doesn't work. So that would be a little bit of my concern there. Oh, you're so welcome. I'm glad. I try to do everything that in a way that helps people understand this. Rodrigo, I really appreciate that. Very, very nice. And with that, I think that's all I've got today. I really appreciate all your comments. I will be back here next Friday if you want to follow up on any of those, or anybody else that's watching this later that missed it. There's no podcast recording of this like there is for Better Than Ever Live on Thursdays. It's only on YouTube, not on Facebook, not on LinkedIn like Better Than Ever Live. And I don't really have time or the ability to answer questions in any other format. Comments to YouTube videos, whether it's emails to me, things like that, I just can't do that. So with that, I'm going to say, and Rodrigo, I'm sorry I'm cutting you off, but bring that next Friday and I will get to that. Thank you guys so much. Have a great weekend. I'll see you next Friday. Take care.